if the sound quality has improved. Mr. Thériault, is it better now?
Oui, c'est mieux.
Yes, it is better now. Mr. Kitchen, is it working better for you? Are you hearing interpretation?
C'est bon maintenant?
Yes.
Okay, thank you. All right, I'm going to start at the top because we barely got into it. Welcome to meeting number 114 of the House of Commons Standing Committee on Health. Before we begin, I would like to remind all members and other meeting participants in the room of the following important preventative measures to prevent disruptive and potentially harmful audio feedback incidents that cause injuries. All in-person participants are reminded to keep their earpieces away from all microphones at all times. As indicated in the communique from the Speaker to all members on Monday, April 29th, the following measures have been taken to prevent audio feedback incidents. All earpieces have been replaced by a model that greatly reduces the probability of audio feedback. The new earpieces are black in color, whereas the former earpieces were gray. Please only use a black approved earpiece. By default, all unused earpieces will be unplugged at the start of the meeting. When you're not using your earpiece, please place it face down in the middle of the sticker for this purpose that you will find on the table as indicated. Please consult the cards on the table for guidelines to prevent audio feedback incidents. The room layout has been adjusted to increase the distance between microphones and reduce any chance of feedback from ambient noise, from an ambient earpiece. These measures are in place so that we can conduct our business without any more interruption, and to protect the health and safety of all participants, including the interpreters. Thank you for your cooperation. In accordance with our routine motion, I'm informing the committee that all remote participants have completed the required connection tests in advance of the meeting. Pursuant to Standing Order 108 Sub 2 and the motion adopted on November 8, 2023, the committee is resuming its study of the opioid epidemic and toxic drug crisis in Canada. I'd like to welcome our panel of witnesses. We have with us here in the room Dr. Sharon Koivu, addiction physician, and online Dr. Bernadette Pauley, professor and scientist with the Canadian Institute for Substance Use Research, School of Nursing at the University of Victoria. Also by video conference, representing the Thunderbird Partnership Foundation, Dr. Carol Hopkins, Chief Executive Officer. And finally, as well by video conference, representing the Vuntut-Gwitchin First Nation, Chief Pauline Frost. Thank you for your patience to all of our witnesses. Thank you for being with us. Parliament Hill is a place where rumors are a constant, and I heard a rumor today that there's going to be a vote in roughly 45 minutes. If that happens, the meeting is likely to be interrupted, and we will likely be asking you to stay a little later than you might have anticipated. So if you are able to stay with us to ensure that everyone gets a chance to fully converse the matters with us, it will probably result in your time with us being extended from 5:30 until 6 o'clock or a little later. So I'll give you a heads up for that. And we can now go ahead with our opening statements, beginning with Dr. Koivu. You have the floor for the next 5 minutes. Welcome to the committee.
Thank you, Mr. Chair, members of the committee. I've been a physician for 39 years. I have my certificate of added competency in palliative care and addiction medicine from the College of Family Physicians of Canada. I began working in addiction medicine in 2012, and until 2021, I was the sole healthcare provider offering comprehensive consults in addiction medicine at London Health Sciences Centre, where in 2023, an interprofessional addiction team was established. I also provide addiction consults in St. Thomas. I decided to speak out to bring a voice to the horrific suffering I have witnessed from Safe Supply. Early in my addiction career, I identified a link between injecting long-acting hydromorphone capsules and developing a heart valve infection. An infectious disease specialist I work with found a link with injecting these capsules and getting HIV. When this specialist and the department chair took our findings to the community agencies, we were initially criticized and called fearmongers. Fortunately, we established community engagement and developed an integrated response. As part of the response, in 2016, London Intercommunity Health Centre developed a program which provided high-risk sex workers using hydromorphone capsules with short-acting hydromorphone tablets, also called Dilaudid. This was the inception of the Safe Supply program in London. I initially supported the program. It is important to note that we did not have a problem with illicit fentanyl at this time. Prior to the Safe Supply program, I rarely saw people with spine infections. In the following summer, I saw 5 patients in 1 month. The numbers continued to climb. The common thread among patients was that they were injecting Dilaudid tablets. Many told me they were buying diverted Dilaudid from Safe Supply program. Some patients were in the program. I had patients who were housed using clean equipment and only injecting Dilaudid, developing horrific infections. Spine infections cause perhaps the worst suffering I have ever seen. Not only are they unbearably painful, they can also cause paraplegia and quadriplegia. In June of 2018, I had my first patient tell me that he left his apartment to live in a tent near the pharmacy close to the Safe Supply clinic in which much diversion takes place because the Safe Supply pills were cheaper and more abundant near the source. I lived in the neighborhood and watched this encampment grow. Since Safe Supply, I've been involved in about 100 hospitalizations of patients with spine infections, currently about 1 per month. Spine infections are only a small part of the suffering that we see. About 30 patients per month are admitted with another severe infection. Of patients admitted with opioid use disorder, 25% were receiving a Safe Supply prescription, and 25% reported using diverted Dilaudid. Only 4% of the consults we see were for unintentional overdose. Generally in hospital, we start patients on home medications. If we did this for Safe Supply patients, the results could be fatal. This is dangerous for patients and very stressful for healthcare providers. For example, patient 1 was prescribed Dilaudid 8 milligrams, D8s, 40 tablets per day, and long-acting morphine 100 milligrams, 9 capsules per day. When they were given less than half of their prescribed dose, they had a severe respiratory depression, that is, toxicity. Patient 2 has frequent admissions requiring intubation. They were prescribed 28 D8s per day, tolerated about 6 to 8, and said they never take more than 12 in a day. The patient population has changed. I see more young patients, many more men, and now most started opioids recreationally and not with a prescription for pain, as was the case in 2012. I am repeatedly hearing disturbing stories that people with prescriptions are vulnerable to violence. Importantly, as I mentioned previously, when Safe Supply started in 2016, we did not have a problem with illicit fentanyl. We do now. Many patients have told me they sell or trade much of their prescribed Safe Supply to buy fentanyl. Others not in the program have told me that their dealer claims to be out of Dilaudid and has sold them fentanyl, starting them down this path. Safe Supply appears to be contributing to the illicit fentanyl crisis. Safe Supply is not reducing illicit fentanyl or its harms within a community. Our hospital experience also shows that Safe Supply is preventing patients from choosing opioid agonist therapy and the opportunity for recovery. I would like to mention a program that is showing significant benefits. The Community Health Center in St. Thomas has a low-barrier approach using subcutaneous buprenorphine, also called Sublocade. They are having success serving a very similar population to London Intercommunity Health without the unintended side effects. It should be a model that we are discussing. Of note, I have broad shoulders. I found some of the comments made by Dr. Sarita on February 26th about me and cardiac surgeons to be misleading, and I do look forward to some opportunity to address this. Thank you for your work and your time. Merci, miigwech.
Thank you, Dr. Koivu. Next, Dr. Pauly, please, for 5 minutes.
Good afternoon, and thank you for the opportunity to be here. My name is Dr. Bernadette Pauly. I'm a professor in nursing at the University of Victoria and a scientist at the Canadian Institute for Substance Use Research. I'm a member of the research team conducting the BC provincial evaluation of prescribed safer supply. Prior to introduction of the prescribed safer supply policy, the evidence of need for that intervention was well demonstrated by the overdose deaths caused by the unregulated drug market. However, it's critical to generate evidence of ethically justified interventions and determine whether or not prescribed safer supply reduces overdose risk. To answer that question, our team designed a rigorous mixed method study using state-of-the-art approaches combining administrative and primary data. In January of 2024, the team led by Dr. Sloan White and senior scientist Dr. Nosik published the first ever population level study in British Medical Journal, a high impact journal. The findings were that everyone receiving risk mitigation or prescribed safer supply prescriptions, everyone was included in the study who received it and carefully matched with people not receiving it on multiple variables, including receipt of opiate agonist treatment. For those receiving opioids through this program, the risk of dying from any cause was reduced by 61%, and risk of dying of an overdose was cut in half. If they received 4 days or more, their overdose risk was further reduced to 89%. This is known as a dose-response relationship, and the finding was independent of opiate agonist treatment. A similar pattern was found for stimulants, but the sample size was smaller, so less certainty. This protective effect continues as long as people are able to, week after week, as long as they're able to access a prescription. However, only 7.6% of those with an opioid use disorder and less than 3% of those with a stimulant disorder received the intervention during the period of study. So there was limited implementation, with implementation mainly occurring in urban areas like Vancouver and Victoria, and among prescribers who had larger caseloads of people with substance use disorder and more complex problems. While the intervention did not fix all their issues, nor was it expected to, it was protective for reducing risk of overdose death and all causes of death. In a qualitative analysis, we found that prescribers were hesitant to take up the intervention out of fear of audits from regulatory colleges, as well as criticism and censure from colleagues. Where there were networks of prescribers who had support, there was increased continuity of prescribing. However, prescribing alone is an inadequate response to a systems issue, namely prohibition and an unregulated, unsafe supply of drugs. The intervention was often difficult to access. Participants in the qualitative arm of the study reported the need to climb a steep staircase with many steps. Often, potential participants did not know about the risk mitigation guidance or safer supply. When they got their hopes up, they had to find a prescriber and navigate highly medicalized systems to get an appropriate prescription and then pick it up daily to keep it. This required self-advocacy and fortitude. In a primary survey of 197 people, less than half of participants received a prescription sufficient to reduce withdrawal. Reducing withdrawal is a minimum requirement, so there's room for improvement. Prescribed safer supply is not a competitor to OAT or any form of treatment. It provides a pathway for people to access a life-saving intervention as part of individual recovery journeys. It does not replace or threaten the need for treatment. In fact, treatment options must be available for people if and when they are ready as part of a system of care. In spite of this, the number of people dispensed a prescription in BC is decreasing. Fears of diversion causing death are unfounded. Hydromorphone was detected in 3% of overdose deaths in 2023. It's unregulated fentanyl that's responsible for 85% of the toxic drug deaths. The root problem driving this emergency is toxic drugs, which is a consequence of prohibition. The unregulated market is accessed by those with substance use disorders and those without. We need to expand access to alternatives beyond the healthcare system to ensure safe and regulated access to substances of known safety, quality, and composition. We should be scaling up, not scaling back, safer alternatives to the unregulated drug market and looking to end prohibition. Thank you, and I look forward to the questions and comments.
Thank you, Dr. Pauly. Next, on behalf of the Thunderbird Partnership Foundation, Dr. Carol Hopkins. Welcome to the committee. You have the floor. I'm
Carol Hopkins of the Lenape Nation here in southwestern Ontario. I'd like to acknowledge the lands that you are joining us from, or we're all coming together today. In 2023, First Nations deaths due to drug poisoning were 36 times that of the general population in Ontario. And in 8 short years, from 2016 to 2023, First Nations death due to the toxic drug supply grew 33 times that of the Ontario population. During the pandemic from 2019 to 2022, 28% of First Nations used opioids in a harmful way. 18% used methamphetamines to survive an environment where there were no resources for housing, food security, and income security. Those that reported food security were 2 times more likely to use methamphetamine, according to a survey that Thunderbird ran. 40% of First Nations reporting methamphetamine use felt hopeless to change their lives. And it was this hopelessness that increased their risk for using opioids in a harmful way. This population also reports a high rate of trauma, grief, and loss, and with a lack of resources close to home to support their mental wellness. Fentanyl, benzodiazepines, and xylazine have been increasing across all regions of Canada, including First Nations, and are core to the opioid and a toxic drug crisis that we are talking about today. The impact of these drugs requires community-based health resources that often First Nations communities lack. First Nations communities declaring a state of emergency report no capacity for preventing deaths due to the toxic drug supply. The vulnerability, report also their vulnerability to gangs, to gun violence and murders, as well as human trafficking that is now present in many First Nations communities for the first time. The war on drugs, including the criminalization of people for their health and social needs, has been longstanding experience of First Nations people in Canada, who are only 5% of the population and yet represent 32% of those incarcerated, and Indigenous women represent 50% of the incarcerated population. The war on drugs and incarceration has not increased safety from the toxic drug supply, has not reduced crimes of survival for people who live with opioid dependency, nor has it eliminated the illicit and toxic supply. Indigenous Services Canada does not provide for physician or pharmacy services in First Nations communities. And we know that that's a responsibility of the provinces and territories. So in this context, the opioid crisis and toxic drug crisis are not just a geographical issue, meaning rural and remoteness of First Nations communities are exempt from the toxic drug supply or the opioid crisis. The crisis actually is a lack of equitable, available, and accessible health care for First Nations, such as a lack of access to primary health care, physician services, pharmacy, and to public health resources, all necessary components of a response to the toxic drug crisis. Live-in drug treatment aimed at abstinence is not the evidence-based for addressing opioids, and it is not the first line of evidence-based intervention. Abstinence-based programs will not change drug dependency or address the physical withdrawals from opioids. Where live-in treatment programs have additional resources, for example, through provincial health authorities, harm reduction networks, and First Nations governed culture-based, land-based services, and have options to readmit or keep First Nations on a continuous basis, clients have gone on to employment obtaining housing, and maintaining their own wellness. Buprenorphine treatment initiated either by the community's primary care physician when they are lucky enough to obtain a partnership, or through addictions physicians through telemedicine or fly-in locums dispensed daily under supervision, has proven effective, along with a recovery program involving community mental health workers who provide both conventional counseling and culturally relevant healing practice. This comprehensive approach has enabled many patients or First Nations people to stop or manage their opioid use with a return to work, school, and family. A year after such programs have been initiated, criminal charges and medevac transfers decreased. The needle distribution program dispensed less than half its previous volume, and rates of school attendance increased. But addressing the opioid crisis has been challenging for First Nations communities, most significantly because of inconsistent support and resources to community-governed and culturally relevant treatment. One study of community-based opioid misuse reported that among adults aged 20 to 15, 28% were on buprenorphine naloxone, double the rate of adults in the community living with type 2 diabetes. First Nations people have the right to live life. They have the right to the sacred breath of life, and that has to be our focus in any drug policies that are humane and sensible for First Nations communities. First Nations communities require increased capacity for reducing harms related to opioids, opioid analogs, methamphetamine, xylazine, such as consistent support and access to prescribers, pharmacy, safe housing, food security, medication to address withdrawal, and a choice to continue to use drugs safely. Harm reduction kits and resources are needed. Human resources
Dr.
are also needed.
Sorry to interrupt. If I could get you to wrap up, you will get a chance to expand on your presentation in questions and answers.
Thank you.
Okay.
Human resources are needed in community, and the existing resources of treatment centers can also play a role, but they need additional resources and capacity as well. Thank you.
Thank you. And last but not least, from the Vuntut Gwitchin First Nation, Chief Pauline Frost, thank you for being with us. You have the floor.
Thank you. I appreciate the opportunity today. I am the chief of a very small fly-in community.
Excuse me, Chief
Yep.
Frost. I'm sorry.
Okay.
The bells are ringing, and that means that we're obligated to go and vote unless we have unanimous consent to continue on. Do we have unanimous consent to allow Chief Frost to finish her opening statement before heading off to vote?
Monsieur le Président,
Oui.
pendant qu'on...
Chair? In the room, can we lower the volume in the room so that I can hear interpretation without having to increase volume? I find the room volume too high.
Exactement le contraire de le début.
So we're having the opposite issue than what we were having at the start of the meeting.
Ça, c'est un problème qu'on devrait...
This is something that should be solved at the start of all meetings. There should be sound tests. It's not the first time that I've had to do this, and I didn't want to interrupt the witnesses, but it can be difficult to follow interpretation.
Okay, is there anything we can do about that? Okay, Mr. Thériault, est-ce que
Mr. Thériault, is it any better? Inaudible.
Chief Frost, sorry for the interruption. You go ahead and finish your opening statement, and we'll likely suspend once you're done. So you have 5 minutes. Go ahead.
Okay, thank you. I, as the former Minister of Health and Social Services for the government of Yukon, I was responsible for the identifying with the opioid crises as well as the COVID pandemic. At the same time, I worked as a lead negotiator for my First Nations, a small isolated Aboriginal community in North Yukon. We signed our self-government 30-some years ago. We exercise our inherent right to self-determination. We have responsibilities for the general welfare of all citizens, our community, the land, and the resources. As an isolated community, we're resilient people, resilient in that we are connected to our roots, our traditions. At the same time, we are deeply affected by the opioid crises, the toxic drug overdoses in the Yukon and across this country. The serious challenges that we face and the high cost of living, food security is huge. Fiscal capacity is limited in our communities, causing significant challenges. Addressing mental health and substance use challenges have arisen in our history due to colonialism, racism, intergenerational trauma. All of this is a priority for my community. In April of 2023, we declared a state of emergency and substance use crises in my community. The reason for that is we've suffered significant loss due to opioid and alcohol drug use and abuse. Over the last 5 years, we've lost 15 Vantakwichan citizens linked to substance use. Now, because of the small community, it's very complex and it affects everyone, compound impacts and effects. Every person in my community has been affected in one way, shape, or form. Because we're an isolated community, our citizens are required to travel out of community for amenity support, medical supports, and therefore we tend to see impacts and effects when they do get to the city. So an urban center effect on Aboriginal Northern isolated people. We have worked tirelessly to support our citizens the best we can with healing and wellness. Our approach has been comprehensive and non-judgmental. We commit to facilitating easier access to treatment services. We set aside last year almost $1 million in supporting our citizens to access treatment programs. That comes out of our base funding that we get for programs and services from our FTA base. Ensuring consistent availability of counselors both locally and remotely is a priority for me as a chief, and we are developing aftercare programs that provide supports to our community. So what I'm saying here is we are working hard to combat the supply of substance use into our communities. We are utilizing the Yukon Safer Communities Neighborhoods Act to address and combat the drug trafficking and bootlegging. We've asked for changes to the security designation for our northern airports to implement passenger baggage and freight screening for northbound routes equivalent to southbound. So in other words, the drug traffickers can come into our community without restrictions whatsoever because we're remote fly-in. We're limited. Our tools are limited. But we are making significant headway, and we have sent over 70 people to a treatment facility in southern parts of the BC because the Yukon is not equipped. Treatment options are not available to us in the Yukon. We are limited availability. We need more. My First Nations need support to implement our programs and improve wellness of my people. As we are on the ground, we know what's happening. We have the flexibility, but we are also trying to address the crises. Adequate and secure funding for life-saving interventions is not going to save us. It's not going to help us. We need more supports in addressing the illicit overdoses and program services. We also look at a piecemeal funding program available to us through the federal government and territorial government, which is not sufficient. We just had asked last year at the Prime Minister's Forum direct access to funding and support, put it in our base and let us provide services. We don't have that flexibility. There needs to be consideration of political, social, economic, and cultural pressures that we're facing. So I want to just quickly say that we just finished a coroner's inquest in the city of Whitehorse in Yukon for 4 overdose deaths at the emergency shelter facility. 2 of those individuals were residents of my community. We also are proud of our community because we are resilient. We've done amazing. We own an airline. We don't have a housing crisis, but our people are directly affected. We have to make a meaningful difference in the services that's provided, and the only way forward is by working together, jointly addressing. We have looked at options, exchange coming into a community. We've educated our citizens. We have looked at alternative options. We are totally looking at a recovery withdrawal supports in our community. We also have to look at a distribution program. Everything we need to do is building on healthier families, healthier communities. For the first time, we are actually focusing now on our young people, and we have a youth program, a youth wellness program that we're bringing our youth together. Facilitators are coming in. Thank you. Appreciate this time.
Thank you, Chief Frost. Okay, so we're going to suspend now to allow for members to vote. You can expect the suspension to last for about a half an hour, and then probably about an hour of questions, more or less. So stretch your legs, and we'll be back to you once we've voted and returned. The meeting is now suspended.